Very excited for your session about DOACs in adolescents. Certainly a topic I know very little about. Thank you, Leo.
Good morning, everyone, in person and virtually. It's very exciting to see many colleagues and friends. Apologies, Maha. I'd like to start by thanking the planning committee for giving us the opportunity to share some thoughts on this topic. Thank you. And particularly Dr. Castellucci, Tsang, and Carrier. Let's get started. Before a few disclaimers, I would ask an adult audience to shift down your ears to pediatric thrombosis literature. When Dr. Carrier, he didn't make fun, but he pointed out the SELECT-D study had 400 patients. Not enough. We would die to have a study like that. A second comment is that we have a love-hate relationship with thrombophilia, as you will see throughout the lecture. These are my disclosures, our conflicts of interest. And this is, again, how Thrombosis Canada is trying to mitigate potential biases. So the objectives of our now next 29 minutes or so are twofold. Before I review DOACs in adolescents, I'm going to try to put some concepts in perspective for you to appreciate what the DOAC findings have been. So let's quickly review the epidemiology of VTE in adolescents before we dive into the results and limitations of what we know so far. And at the end of last century, so in the 90s, a lot of what pediatric treaters knew about venous thromboembolism arose from international pediatric thrombosis registries. Canadians can be very proud because the late Maureen Andrew led perhaps the biggest and still most comprehensive registry to date. What you see in front of you is a combination of the registry from the UK, Canada, and the Netherlands, noting that the Netherlands, the Dutch registry included neonatal thrombotic events. And pediatric treaters are now familiarized with the bimodal distribution with a second peak of prevalence during adolescent years. So highlighting a few details related to DOACs as one envisioned treating such a patient. The recurrence is much higher in adolescents in contrast to the other population, pediatric population, where VTE is also common. A little less than 10% of those events in adolescents were of idiopathic nature, and overall, close to 50% of all VTEs throughout childhood occurred in this age range, i.e. adolescence. Why are we focusing on VTE? On the left, you have a representation of a service called 1-800-NO-CLOTS. This has been a 24/7, originally by those prehistoric pagers that I still have held to my belt, that Dr. Andrew and trainees would answer phone calls from all over the globe. And we can see the vascular territorial occlusion distribution contrasting neonates and adolescents, and the vast majority of adolescents presenting with VTE, hence the focusing on this territory from now on. Specifically about VTE locations, in addition to the preponderance of upper and lower extremity occlusions, we can also see, of note, 10% of those events representing PE and some other odd locations, or not so odd for pediatric treaters. Let's fast forward 10 years, now looking at a single center experience with 10 to 14 years of follow-up of the patients that are being represented on this slide. You can see on the upper part a division between upper and lower DVTs, and on the horizontal axis of your slide, we have three different pediatric patient categories disposed as follows. On the left, the so-called unprovoked or non-catheter related DVTs, of which the median age was 14 and 16 years respectively for the patients depicted here. Number two, line-related thrombotic events in neonates. And number three, line-related provoked DVTs in non-neonates. First, for the outcome pulmonary embolism as a complication, it's immediately easy to identify patients with unprovoked events being the ones where more commonly PE occurs. Moving to a second outcome, DVT recurrences, establishing or following the same division I had done previously, lower extremity and upper extremity amongst the three categories, except for upper extremities, where it's not uncommon to have patients living with the medication or parenteral nutrition coming from an upper venous, central venous catheter territory that causes several recurrences. I think it would be still fair to say DVT recurrences occurred much more commonly, be it on the arm or on the leg, in adolescents with these unprovoked or non-catheter related events. And finally, for the outcome post-thrombotics before that, let me bring to your attention, because this is relevant to someone in whom you're thinking about giving DOACs. 2/3 to 3/4 of the adolescents that presented with the so-called unprovoked events within the next 12 months from the diagnosis had one of the following conditions: the so-called anatomical thrombophilias, either IVC anomalies or occlusions such as thoracic outlet or May-Thurner. Around 20% of them will have a rheumatological condition, SLE, for example, in whom antiphospholipid antibodies is common. And number 3, IBD, in whom DOAC have also a corollary of complications and absorption, not to mention major thrombophilia. Now let's move to the third outcome, post-thrombotic syndrome. And let me go fast here. This is a post-thrombotic syndrome free survival curve, dividing them again on the blue, adolescents with unprovoked events, green, non-adolescents line-related, and red, neonatal line-related provoked. This is the time it took for half of those subpopulations to develop post-thrombotic syndrome based on the diagnosis made by a pediatric PTS tool called Modify Vilauta, approximately a year to a year and a half on the adolescents with unprovoked events, approximately 3.5 years to the non-neonatal line-related events, and approximately 10 years on the neonates with line-related events. And the difference of timing for half of those types of thrombotic events in children to occur mimics what I've just described between upper and lower extremity. Very well, let's shift gears to pulmonary embolism and allow me to share a collaborative study between Ottawa and Toronto with 170 PE pediatric patients in whom the overall mortality was 6%. But if we focus on the massive events, almost 1 in 4 of those patients died, higher than 30% if those PEs recurred, 2/3 of those associated with DVTs. Let's focus now on adolescents because this is the scope of our lecture. And we can identify that close to 70% of all of those PEs occur within adolescent time range. The most common underlying conditions being cardiac cancer and infections, and risk factors, catheters again, obesity, and contraceptives. 1 in 4 of the PEs occurring in adolescents were of submassive and massive nature. In terms of anticoagulation length or time duration of therapy, it's easy to identify, importing from the adult evidence-based literature, that with the majority of pediatric events being provoked, they would be treated for approximately 3 months or less. This is about to change. I'm sure new evidence-based pediatric guidelines will incorporate the results of the recently published Kids trial, randomizing and comparing 500 patients between 6 weeks and 3 months for provoked events. And I'll leave it at that. The remaining of the causes depicted on the left of your triangular pyramid in comparison to length of therapy, that is between 3 and 12 months, are shown. And I won't refer to the more elusive conditions in pediatrics, HIT, thrombotic storm, and catastrophic APS. Of course, in pediatric care, we do not have thrombosis risks that have already been identified in adults to help with the decision of length of anticoagulation therapy, be it sex, D-dimer, or residual VTE, nor do we have bleeding predictors. So I would stop and conclude at this very quick intro on the nature of VTE in adolescents, that it represents a significant and growing percentage of events throughout childhood, that in adolescents, almost half of those events could be considered idiopathic at presentation, and they seem to be accompanied by a higher mortality. And number three, the use of DOACs in this particular pediatric subset includes a thorough investigation because of the underlying conditions those patients maybe more commonly have, and because those conditions may affect absorption of the DOACs, their efficacy and safety. Now that we have put those concepts to ground, let's move and dive into the trial results. Before we do that, I was happy to see and be taught by my colleagues looking at Statistical Canada that the rate of adolescent pregnancy defined between 12 and 19 years in Canada has been in frank decline. 2016, 8,500 cases, 2020, around 5,500. But yet, if an unwanted or unplanned or inadvertent pregnancy occur in adolescents, I hope this table can summarize some data relevant to them. Of course, I discourage DOACs to be given to pregnant ladies or ladies that are breastfeeding. But if we look at what is being called by the FDA cutoff, that is less than 10% of the amount of identified drug level for that given age, that would be for a newborn. Dabigatran seems to be the safest of all DOACs in identifying in case reports, case series, or systematic reviews in the literature, followed by Rivaroxaban. Surprisingly, apixaban, which has characteristics similar to Rivaroxaban, has a much higher concentration when this was looked at in terms of breastfeeding. And doxaban, there's no information. What about transplacental movement of DOACs to the fetus? There is no information, whereas there's no information for dabigatran and edoxaban. Rivaroxaban and apixaban are likely for this to occur. In terms of interaction of DOACs with the blood-brain barrier, affecting the junction between endothelial cells, particularly if there is an intracranial hemorrhage at place. There are animal studies looking at this effect, and in contrast to warfarin and heparinoids, DOACs seem not to have a PAR1 mediated opening of those junctions in the endothelial cells. Finally, or before the finally comes, I'm just reminding the audience what adult treaters already know, that dabigatran clearance really depends on renal function more than 80%, whereas that does not happen to the direct 10A inhibitors. And finally, because a lot of chronically ill adolescent patients may have problems with swallowing DOACs, before it became approved by FDA and Health Canada, parents would have to macerate the tablets. And I'm reminding you that dabigatran and edoxaban should not undergo that process. Dr. Connors just quoted 40% rate of BMI higher than 40 in the States. And by 2030, we will have close to 1 million individuals within pediatric age surpassing BMI of 30, particularly because of the effects of the pandemic. So I'm bringing this reality to the fact that surgical procedures that are bariatric surgery, which is used for adults, definitely affect the DOA absorption in the GI tract. I was also taught that in Canada, St. Justine and CKids have been offering this for more than 10 years. So currently there are between 100 to 150 of such patients in whom, if you encounter, you should pay attention to avoiding it. Let's now dive into the trials. That was a lot of introduction. I'm going to divide the trials into 3 categories depicted on the second, third, and fourth column in front of you. Treatment of VTE, secondary prevention of VTE, and pediatric patients that are receiving primary prevention because of an acquired or inherited cardiac defect or arterial thromboembolic event. I'm going to share with you three of the phase 3 trials that have already been published. Starting with the fact that for all DOAC studies, these efforts started more than 10 years ago after the EMA and FDA partner to allow what are called pediatric investigation plans to move forward. A combination of in vitro physiologically based PK studies, phase 1 and phase 2 studies in pediatrics occurring between 5 to 8 years culminated on the phase 3 trials that I'm about to share with you. Before I do that, I would like to certify that the doses that are currently being recommended for pediatric patients, adolescents or not, have already shown in comparison to adult studies that regardless of age, formulation, be it oral or in tablet form, body weight or treatment regimen, once a day, twice a day, or 3 times a day, are within the 5th and the 95th percentile encounter in adults. So let's review the phase 3 EINSTEIN-Jr. randomized trial that involved more than 100 sites throughout 28 countries throughout the world. 500 patients were randomized on a 2-to-1 ratio for this parallel open-label randomized study. Individuals with an objective documented VTE were initially treated with standard of care for up to 5 to 9 days, and then they would start receiving a Rivaroxaban dose equivalent to 20 milligrams of the adult trials. They would be treated for 3 months and had a final imaging study at the end of therapy. The efficacy endpoints was prevention of fatal and symptomatic non-fatal recurrence. The safety endpoints, major or clinically relevant non-major bleeding. As I had mentioned before, on patients with weight 30 kilos or higher, once a day dosing was allowed, which refers to adolescents. Approximately 55% of patients enrolled in the entire trial are adolescents, and therefore most of what I'm going to continue to share with you pertains to this talk. The 3 most common risk factors associated to patients entered. Approximately 25% had cerebral sinus venous thrombosis. Surprisingly, only 25% or so had catheter-related VTE, and approximately half of all patients had non-catheter-related VTE. Transient risk factors and transient and/or persistent were responsible for most of those events, and major surgery or trauma, major infections conditions, or major organ disease were the most common risk factors. So this is the most important slide of this trial, sharing with you the recurrence VTE rate of 1.2% in contrast to 3% of standard of care. In terms of safety, we had 3% of major or clinically relevant non-major bleeding. For Rivaroxaban, they are all clinically relevant non-major, in contrast to almost 2% on the comparator. Another perk of this study was showing residual thrombotic burden, which had statistical significance for clearance of the venous thrombotic territory that was originally occluded. Let's move now to the Dabigatran program. Similarly to what has happened with Rivaroxaban, there was an entire program preceding the phase 2b/3 trial for almost 10 years. A combination of in vitro phase 1 and phase 2 studies have culminated on that trial. And the doses were confirmed by population PK modeling. The difference is that Rivaroxaban established its dose appropriate based on weight only, whereas for Dabigatran, because of the renal clearance dependence, the algorithm, or for the pharmacists and the audience, they use the Hilton formula, adjusting for weight and age. It doesn't project well. If you look on the second square on the right of your slide, the very number on the upper top you will see a dose of 330 milligrams BID, which was, again, generated by PK modeling to adjust for the clearance, which in adolescents would be higher than in adults. So diving into the trial, 267 patients were randomized on 26 countries on, again, 2-to-1 ratio. Dabigatran as administered in capsules, pellets, and oral liquid formulation, and they would have received standard of care for up to 3 weeks, differently than Rivaroxaban that would have received for up to 9 days. At the end of therapy, imaging was also obtained. The primary composite efficacy endpoint was the proportion of patients with complete thrombus resolution, freedom from recurrent VTE, and freedom from VTE-related deaths. For safety, we had freedom from major bleeding events and incidence of clinically relevant non-major bleeding. A comparison of the proportions of individuals treated with dabigatran versus standard of care for all of those efficacy endpoints was similar, proving non-inferiority for this trial. In terms of major bleeding events, 2% treated with dabigatran had major bleeding, in contrast to approximately 3% for standard of care. Dabigatran relationship to diluted thrombin time and eccrine time was linear throughout all age groups, particularly in adolescents, whereas the relationship with APTT was nonlinear, including adolescents. I had already mentioned, or maybe not, the freedom from recurrence of VTE, 96% for dabigatran and 92% for standard of care. For any bleeding, 20% treated on the dabigatran arm had any type of bleeding, 2% major bleeding versus 24% for standard of care. And finally, this was the extended dabigatran trial. Patients were treated for up to 12 months, 204 of those. I would bring to your attention that in this trial, 75% of patients included were adolescents. 45% of them had an inherited thrombophilia, 10% had antiphospholipid syndrome, and 10% had anatomical thrombophilia. So not necessarily the usual adult patient you usually see. This was mostly a safety trial where recurrence of VTE, mortality, and bleeding events were described. Here you can see the rates of recurrence, 1.3%, the rate of any bleeding, 24%, and of major bleeding, 2%, and the rate of PTS newly identified, 1.6%. Time to recurrence for VTE and PTS is depicted. There were 2 female adolescents that developed recurrence. They were both with inherited thrombophilia, and there were 3 males that developed mild PTS within the year of the trial. Shifting gears to reversibility of DOACs in adolescents. Instead of sharing with you ad hoc publications, because there are none, I look at a recent systematic review. On the left part of your slide, you can see a composite of 16 trials looking at PCCs for reversal of major bleeding events in adults treated with direct 10A inhibitors. On the right part of your slide, you can see 4 studies reporting similarly hemostasis effectiveness on panel A and thrombotic event complications on panel B. There's comparison of effectiveness for hemostatic capacity comparing PCCs and andexanet alpha. Conversely, perhaps there's a bit more of safety when using PCC for its reversibility. There are several limitations to this. None of these studies had a control group to compare to, but the point of me showing this slide is to cite the number of pediatric patients included, 0. Before shifting to adarisuzumab, I need to bring to our attention that there is this concept of developmental hemostasis, where babies, the younger they are, all of their vitamin K dependent factors will have a different concentration in comparison to adults. PCCs have obviously vitamin K dependent factors. So the rate of thrombin generation that would be required for a child perhaps differs to reestablish hemostasis in comparison to an adult. And I presume this is relevant. Should we have pediatric trials looking at this? Secondly, there are particular instances, perhaps an equivalent of coronary artery disease would be Kawasaki disease, where a superantigen may cause coronary aneurysms that may occlude. Similarly, single ventricle patients are extremely prothrombotic, and they will be receiving DOACs for primary prophylaxis. Finally, looking at what we have in pediatric literature in idursulizumab, there's only one case report of a 15-year-old female who attempted suicide taking between 30 to 50 tablets of 150 milligrams each. The Dabigatran concentration surpassed 2,000 nanograms per ml, and after receiving the regular dose of idursulizumab published on both cohorts in New England 2015 and 17, there was full reversal of the medication. Berger Ingerheim was nice to share with me from the final cohort a number of patients included in the trial that had less than 70 kilos, So you can see that out of the total of 503 patients included on that trial, 35% of them had weight between 35 and 69.9 kilos, but only 5 of those had less than 40 kilos. The regular doses also successfully reversed on this subpopulation. The final and pragmatic topics that hopefully we'll be able to continue to discuss on the afternoon session. I will remind you again that for all of these studies, patients receive standard of care between 1 to 3 weeks before they commence receiving DOACs. For the upcoming DOAC studies, I suspect there will be differences. Many pediatric patients not necessarily have mechanical heart valves, but have mechanical intracardiac devices because of their congenital heart defects. And one would immediately question the efficacy of DOACs in such patients. I've already alluded to the higher frequency of antiphospholipid syndrome in adolescents, as well as the growing prevalence of obesity. And finally, conditions associated with thrombotic events in adolescents, naming IBD, thrombocytopenia, and LPs in patients with acute lymphoblastic leukemia, inadvertent pregnancy and breastfeeding, renal and liver dysfunction, which are certainly very different from the ones from the exclusion criteria, and menorrhagia. I know there will be a lecture this morning. So I will conclude that DOACs may potentially overcome the challenges of anticoagulation in children and adolescents, and that to date, only Rivaroxaban and Dabigatran have published their results, including for thrombosis for line-related events and cerebral sinus venous thrombosis. They seem to have an acceptable safety profile, including secondary for prevention, but different formulations. I mean, oral or pellets or capsules that can be diluted will also be available for adolescents that are not able to swallow. And with that, I think we've covered a lot of ground. Thank you for your attention.